Welcome to the Concierge Care Health System podcast. The information shared in this podcast is for general informational purposes only and does not constitute medical advice. Listeners should be aware the content is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with a physician or other qualified healthcare provider for medical questions.
Welcome to the Deep Dive. Today we're tackling something surprisingly common, tremors.
That's right. These involuntary shakes, they're actually the most frequent movement issue doctors encounter.
Yeah, and they can range from, barely there to really quite disabling. If you or someone you know has dealt with this, it can feel pretty baffling.
Absolutely. And our mission today is to really get into a key distinction: functional tremor versus physiologic tremor.
Okay.
They might look similar on the surface, but where they come from, how they behave, how you treat them, total different worlds.
And getting that diagnosis wrong can cause real problems,
Yes.
right? Unnecessary tests, treatments that just don't work.
Precisely. A lot of frustration for everyone involved.
So we're going to unpack this. We'll use this idea of software glitch versus hardware hum to make sense of it. Stick with us. You might find some surprising things here. Okay, let's start right at the beginning. What exactly is a tremor?
Fundamentally, it's an involuntary movement, but the key things are that it's rhythmic and oscillatory, like a back and forth.
Rhythmic. Okay, so that sets it apart from other involuntary movements. Things like chorea, which is more dance-like, or myoclonus, those sudden jerks.
Exactly. That regular rhythm is the defining feature of a tremor.
And when doctors first see someone, how do they start categorizing it? I know there's this idea of when it happens.
Right, the activation condition, that's often the first step. So you have resting tremor, that's when the limb is totally relaxed, supported, like the classic pill rolling you see sometimes in Parkinson's.
Okay.
Then there's action tremor. That pops up whenever you voluntarily contract a muscle.
And there are different types of action tremor too, right?
Yes. So postural tremor is when you hold a position against gravity, like holding your arms out. Kinetic tremor is during an actual movement, like, say, lifting a cup. And if that kinetic tremor gets worse as you get closer to your target.
Like reaching for the cup handle.
Exactly. That's called an intention tremor, often points towards the cerebellum, part of the brain coordinating movement.
Got it. So looking at when it happens gives you initial clues.
It does, but it's just one piece. The more modern approach, like the system from the International Parkinson and Movement Disorder Society, is two axes.
Two axes. Okay, how does that work?
Well, axis one is about the clinical features, what it looks like, where it is, when it started, any other signs, basically describing the tremor itself.
Okay, the what, where, when.
Right. And axis two is about the etiology, the underlying cause. Is it genetic from something else like a stroke, drug-induced? Or, critically for our discussion, is it of indeterminate or functional origin?
So this framework helps sort out tremors that might look alike but have totally different root causes.
Precisely. And that's exactly why we need to zero in on functional versus physiologic tremor. They often get confused, but this framework helps us separate them.
Okay, let's meet them then. First up, physiologic tremor, or PT. You call this universal.
Yes, universal. It's this tiny, fast tremor that, believe it or not, everyone has. It's just a normal part of how our neuromechanical system works. Usually it's so small you'd never notice it.
Right, totally imperceptible most of the time.
Exactly. But under certain circumstances, think high stress, maybe too much coffee, being really tired, certain medications, this normal tremor can get amplified. It becomes visible.
And that's enhanced physiologic tremor, EPT.
That's EPT. It's not a disease in itself. It's just that normal hardware hum, as you put it, getting turned up temporarily. Usually pretty fast, like 8 to 12 cycles per second.
Okay, so EPT is basically a louder version of normal. Now, contrast that with functional tremor, FT. This sounds quite different.
Very different. FT is considered a pathological condition. It's actually the most common type of functional movement disorder, which itself is a subtype of functional neurological disorder, or FND.
And the key difference is it's not about structural damage, not like a stroke lesion or something.
Correct. It's seen as a problem with nervous system function, a software glitch, essentially. How the brain is sending and receiving signals related to movement gets disrupted.
But the person experiences it as completely involuntary.
Right. Absolutely. They aren't making it happen. But the tremor itself has characteristics like being distractible, we'll get into that, which suggests that brain networks involved in attention and voluntary control are playing a role, even unconsciously.
Okay, so this is the core distinction we need to grasp. PT-APTTT, a normal hardware phenomenon, maybe amplified.
Mm-hmm.
FT, a software issue, a problem in brain function, not structure.
You've got it. And because the origins are so different, everything else follows the course, the symptoms, and crucially, the treatment. Getting this wrong leads people down the wrong path entirely.
Makes sense. So let's talk about who gets these. Are there typical profiles? What usually triggers them?
Yeah, the profiles are quite distinct. For functional tremor, it's the most common FMD, maybe making up like 2 to 20% of referrals to specialist clinics. And there's a really marked female preponderance.
More common in women.
Much more. Ratios reported from 2.1 up to even 10.1. Onset is typically midlife, maybe around 40 or so, and it really impacts quality of life, often as much as neurodegenerative conditions.
Wow. And what causes it? You mentioned it's complex.
It is. We use a biopsychosocial model. So there are often predisposing factors, maybe things like childhood adversity, underlying anxiety or depression, chronic pain, vulnerabilities, basically.
Okay.
Then there's often a precipitating factor, an acute trigger. This could be a physical injury, even a minor one, an illness, surgery, a panic attack, a stressful life event. The onset is often quite abrupt after something like that.
Sudden onset, okay.
And finally, perpetuating factors keep it going. Things like not getting a clear diagnosis, maybe repeated tests that don't find anything, which can reinforce the idea something is physically wrong, fear of movement, lack of support. It's a complex mix.
Right, the whole web of factors. Now, what about enhanced physiologic tremor? Much simpler.
Much simpler, yes. Basic PT is in everyone. APT, the noticeable kind, is also pretty common. One study found it in over 5% of healthcare workers, often linked to stress and caffeine. It's probably the most common tremor primary care doctors see.
And the cause is just those triggers we mentioned.
Exactly. It's a direct, usually dose-dependent amplification. So psychological things like acute stress, fear, being exhausted, pharmacologic, certain meds like some asthma inhalers, SSRIs, steroids, metabolic issues, hyperthyroidism, low blood sugar. And dietary stuff, definitely caffeine, alcohol withdrawal, stimulants.
So the contrast is really stark. For EPT, you're asking, what did you just take? Are you stressed, tired?
Pretty much. It's about recent identifiable factors.
Whereas for APT, it's a deeper dive. Tell me your story. What was going on when this started? That difference in approach is huge, even from the first conversation.
It's fundamental to getting onto the right track.
Okay, let's dig into that software versus hardware idea more. How does this actually play out in the brain?
Right, so for functional tremor, the software issue, we're not talking about lesions you can see on an MRI. It's about how networks communicate. There seems to be a dysfunction in the circuits that handle movement planning, attention, and crucially, the sense of agency.
That feeling of being in control of your movements.
Exactly. Patients often feel the tremor is happening to them. Studies suggest this might be linked to reduced activity in certain brain areas, like the temporoparietal junction, and altered connections with motor areas.
And emotion plays a role.
A big role. There seems to be increased crosstalk between emotional processing areas like the amygdala and anterior cingulate cortex, the ACC, and the motor system. So stress or heightened self-awareness can kind of spill over and trigger abnormal motor output. Interestingly, effective therapy like CBT has been shown to normalize activity in the ACC.
Fascinating. So attention, emotion, movement control, it's all interconnected dysfunctionally.
That's the current thinking. It's a network problem, not a localized damage problem.
Okay, now flip to physiologic tremor, the hardware. Where does that come from?
It's basically an emergent property of a normal, healthy motor system. Several things contribute. Our limbs have natural springiness, a resonant frequency. Tiny forces, even your heartbeat pushing blood around the ballistocardiogram, can set them oscillating slightly.
Huh. I never thought about the heartbeat causing a tremor.
It's tiny, but it contributes. Then you have reflex loops. The stretch reflex in your muscles has a slight delay, which naturally creates oscillation, especially on that 8-12 hertz range for postural tremor. EPT just makes those muscle sensors more sensitive.
Okay.
There are also central pacemakers in the brainstem and cerebellum sending rhythmic signals, and just tiny imperfections in how the brain controls movement, the feedback loops. It's all part of the normal noise in the system. ETT, through increased adrenaline or other factors, just cranks up the volume on all these normal hardware components.
So this explains why manipulating attention works for FT but not PT. If FT involves attentional networks, distracting someone should change it.
Exactly. That's a key clinical insight.
But PT, being this underlying hardware hum, should just keep humming along, regardless of what else the person is doing or thinking.
Precisely. The underlying mechanism dictates the clinical signs.
Which brings us nicely to those clinical signs. How do they actually look different when you examine someone?
We'll start with onset and course. FT is often, though not always, abrupt. Sudden start may be linked to that trigger event we talked about. It often reaches its worst severity pretty quickly. And the course is classically variable. Good days, bad days. Sometimes it even disappears completely for a while, spontaneous remission.
That variability is key. And EPT.
EPT onset is situational. It comes on with the trigger after the coffee, during the stressful meeting. It's transient. Remove the trigger, it settles down. It doesn't progress over time.
Okay, onset and course are different. What about the tremor itself, the movement?
Again, variability is the hallmark of FT. The frequency can change, the amplitude, the direction. It might be jerky 1 minute, smoother the next. It can affect one limb, then shift to another, or be bilateral. Sometimes it can look quite complex or even violent.
Very inconsistent.
Inconsistent, yes. Whereas EPT is defined by stability and consistency. It's high frequency, 8-12 hertz usually, low amplitude, a fine shake, mostly postural when holding arms out, maybe a bit kinetic, typically symmetric in both hands, less likely to affect the head or legs compared to some other tremor types.
Okay, so FT equals variable, EPT equals stable and fine.
That's a good summary. And this leads to those positive signs we look for to actively diagnose FT. Things that demonstrate that inconsistency.
Like the distractibility you mentioned.
Exactly. Distractibility is huge. You give the person a cognitive task like tapping a complex rhythm with their other hand or reciting months backward, and the functional tremor often significantly reduces or even stops while they're focused elsewhere.
Because attention is diverted away from the tremor network.
That's the idea. Another really specific one is entrainment or frequency adaptation. You ask the person to make a rhythmic movement with their unaffected limb, say tapping their foot at a certain speed. And you watch the tremor in the affected limb. In FT, the tremor frequency will often shift and lock on to the frequency of the voluntary movement. It gets entrained.
Wow. That would happen with EPT or other organic tremors.
Nope. Organic tremors have their own inherent frequency. They don't just adopt the frequency of something else you're doing. Other signs include suggestibility, the tremor changing with suggestion, and that feeling of co-activation where agonist and antagonist muscles tighten up together.
So these aren't just oddities. They're direct clues pointing towards that underlying software mechanism involving attention and voluntary motor pathways.
Precisely. They are positive diagnostic signs, not just ruling things out.
All right, so diagnosis relies heavily on this careful clinical observation. What's the overall journey like? And are there times when you need more objective tests?
The clinical history and exam are definitely king. For suspected FT, you need that broad history, the context, the onset, any triggers, physical or emotional, other symptoms. And the exam is an active search for those positive signs. Distractibility, entrainment, variability. Sometimes having someone draw a spiral can visually show the inconsistency.
And for suspected EPT?
Much more targeted history. When does it happen? What makes it worse? Any new medications? How much coffee? The exam is usually normal, apart from that fine, fast postural tremor. No other neurological red flags.
But sometimes it's not clear-cut. That's where other tools come in.
Yes, if things are murky, neurophysiology can help provide objective evidence. Tools like surface EMG, which records electrical activity in muscles.
Use this show.
In FT, you might see EMG bursts that are really variable in length and timing. You might also see that co-activation pattern muscles fighting each other. In EPT, you see a very regular, stable, high-frequency pattern of muscle firing. Consistent.
And accelerometry, measuring the movement itself.
Right. Accelerometry can quantify the tremor's frequency and amplitude. With FT, you might see the frequency peak change or broaden when the person is distracted. And weirdly, adding a weight to the limb might actually increase the tremor amplitude in FT.
Increase it? That seems counterintuitive.
It does, but it's a recognized feature. Whereas with EPT, the frequency peak is sharp and stable, typically in that 8-12 hertz range. Adding weight would usually decrease the frequency, which is the expected mechanical effect.
So these tests can provide objective backup for the clinical impression.
Exactly. And it supports this shift we've seen moving functional tremor away from being a diagnosis of exclusion, where you rule everything else out, to a positive diagnosis based on these specific features. It validates the diagnosis for both the clinician and the patient.
Okay, crucial point. Now let's talk treatment. Since the causes are worlds apart, the treatments must be too, right?
Absolutely critical. Applying the wrong treatment model isn't just ineffective, it can be harmful, reinforcing the problem.
So for functional tremor, the software issue, what's the approach?
It really needs a multidisciplinary team neurologist, specialized physical or occupational therapist, maybe a psychotherapist. The very first step, often incredibly therapeutic, is the diagnosis itself.
Explaining it clearly.
Yes, giving a clear, non-judgmental explanation. Using that software-hardware analogy can be really helpful. Validating their experience, this tremor is real, it's involuntary, while offering a logical reason for it, it's a problem with brain function, not damage, and a path towards recovery. That can be hugely empowering.
What about therapies?
Specialized physical and occupational therapy is key. They use specific techniques, retraining movement patterns, using distraction, mirror therapy to help the brain basically unlearn the abnormal tremor pattern and relearn normal movement.
And psychological approaches.
Psychotherapy, particularly cognitive behavioral therapy, CBT, has the strongest evidence. It helps patients identify and change unhelpful thought patterns and behaviors related to the tremor, manage any associated anxiety or depression, and gradually reduce avoidance behaviors. Some studies show really good remission rates with CBT.
Okay, so it's about retraining the brain's software through movement and psychological strategies. Now, for physiologic tremor and EPT, the hardware adjustment.
Much more straightforward. If it's just asymptomatic PT, reassurance is all that's needed. If it's bothersome EPT, the absolute primary strategy is identifying and removing or reducing the trigger.
Cut back the coffee, manage the stress, review the meds.
Exactly. Address the underlying cause of the amplification. Often, that's enough.
And if not, or if the trigger can't be avoided,
Then you might consider medication. The first-line choice is usually a beta blocker, like propranolol. These block the effects of adrenaline, essentially turning down that sympathetic nervous system overdrive that's amplifying the tremor. They can reduce the amplitude significantly.
can be taken regularly or just when needed.
Yes, sometimes people take them as needed for specific situations, like before public speaking if that's a trigger. Occasionally, benzodiazepines might be used if anxiety is a major factor, but cautiously due to side effects and dependence risk.
So the treatment paths are completely different. Beta blockers for FT would likely do nothing.
Nothing for the tremor itself, no, because they don't target that underlying network dysfunction. And trying ineffective treatments can just lead to more frustration, more tests, feeling hopeless. It really underscores why getting the diagnosis right from the start is paramount.
Makes perfect sense. So finally, what about the long view? What's the prognosis like for people with these conditions?
Again, a real divergence here. For functional tremor, it's kind of a paradox. Theoretically, because the brain structure is intact, it should be fully reversible. It's a software issue you can potentially fix.
But in reality,
Longitudinal studies often show that without the right kind of help, many people remain symptomatic long-term. The prognosis is incredibly dependent on certain factors.
what helps predict a better outcome?
Positive predictors include getting an early and accurate diagnosis. The shorter the time to diagnosis, the better. Crucially, the patient accepting the diagnosis and understanding it, identifying and managing any ongoing stressors, having good social support, and of course, actively engaging in that multidisciplinary treatment, the PT and CBT.
And negative factors.
Long delay in diagnosis, the patient maybe not accepting the diagnosis and seeking endless other opinions, significant coexisting psychiatric issues that aren't being addressed, and unfortunately lack of access to specialized F&D care, which isn't available everywhere.
So prognosis is variable and heavily influenced by getting the right diagnosis and treatment promptly. What about EPT?
Physiologic tremor and EPT prognosis is uniformly excellent. Basic PT is totally benign. EPT is also benign and completely reversible once you sort out the trigger. It doesn't cause any lasting damage. Very different outlook.
It really drives home that for MT, how the healthcare system responds with an early, clear, empathetic diagnosis versus dismissal or confusion can profoundly shape the patient's entire trajectory.
It absolutely can. The diagnosis itself can be therapeutic or harmful depending on how it's delivered.
So wrapping this up, we've seen physiologic tremor is this normal hardware hum, sometimes amplified into EPT by triggers. Functional tremor is a complex software glitch involving brain networks, attention, and agency, showing up as inconsistent tremor.
And the need to tell them apart is more than academic. It's a clinical imperative. Getting it wrong means sending someone down a completely inappropriate path for care.
Right. It leads to ineffective treatments, maybe stigma, frustration. This whole discussion really underlines, I think, how interconnected our brain, mind, and body are, that plasticity.
It does.
And it leaves you wondering, what other physical symptoms might we understand better, maybe treat more effectively, if we paid more attention to the body's software signals alongside checking the hardware? Something to think about. Until next time on The Deep Dive, keep exploring.
Concierge Care, providing world-class, personalized care for patients and members. Taking a proactive approach by offering its free digital health clinic for anyone in need of these services. Reach out to us via our website, www.health.conciergecare.net, or give us a phone call at 786-809-2345.